the Hoag Stroke Program here in Newport Beach and at Hoag Hospital, Irvine. Welcome to our presentation. I'm going to be discussing the little that's known about COVID-19 and stroke at this point, and I hope you find it interesting. Thank you. So a little bit about COVID-19. It stands for the coronavirus disease 2019. The disease caused by the virus SARS-CoV-2, or the Severe Acute Respiratory Syndrome Coronavirus 2. It gets its name by a characteristic crown-shaped microscopic appearance. It's a positive-sense single-stranded RNA virus, or in other words, ribonucleic acid virus, which is what the genetic material is, similar to the DNA in our cells. Along with other coronaviruses, it's believed to originate from bats. Also originating from bats are the SARS-CoV-1, which was another COVID infection, and MERS-CoV. It's transmitted by droplets and airborne, typically by coughing, sneezing, and by speaking, actually, to people. It tends to aerosolize, or even by singing. There's a famous episode in a church that spread quite a bit from some gospel singers. The symptoms of COVID-19 include fevers or chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, and diarrhea. So this is a picture of one of the suspected bat species that may have been the source of the coronavirus. The reason that we think that severe viruses can come from the bat population is because they have a very robust immune system, in part related to their close cohabitation. And as you know, they sleep in colonies very close together and can transmit viruses. But when a very severe virus jumps to another species like us, we don't have the immune system set up to fight it as well. That's why it's different, this pandemic, from, say, a cold virus. And here's a picture of what a COVID virus looks like under an electron microscope. You can see those red projecting proteins, which are the things that bind onto cells and help it to come into the cells and infect us. And inside that envelope that's green is the RNA, which is the genetic material that takes over our cells and helps to replicate the virus. So SARS-CoV-2 spike protein, as those pink elements that I just showed you, act by binding to ACE2 receptors, which stands for angiotensin receptor 2 receptors. These are membrane-bound proteins expressed on multiple organs, such as the lungs, which is why we get respiratory symptoms, but also skeletal muscle and brain. So it can actually invade those tissues directly due to that binding of that spike protein. Neurological symptoms have been reported include impaired consciousness, stroke, muscle aches and pains, something called Guillain-Barré syndrome, which is actually a post-infectious autoimmune syndrome where your body produces antibodies to the virus, but caught as a bystander are the covering on your nerve cells, which causes you to be weak all over. There's only one confirmed case of this reported so far in the United States, but this is a response that can happen to other viruses as well, and it's expected that this number may start to increase as more cases are reported. Also, impaired taste and smell can occur, likely because these are very tightly coupled to nerve cells, so it may be that the virus is invading those nerve cells directly and causing inflammation and damage. COVID-19 is believed to have emerged in Wuhan, China in December of 2019. It was tracked to a wet animal market in the district. As you can see in this picture, Lots of wild animals are being sold, and we believe that's where it got transmitted. It may have been that a bat transmitted it to another wild animal. A pangolin, which is a very early mammal, has been described as one of the possible sources and might have been sold at that wet animal market. It was officially declared a global pandemic by the World Health Organization on March 11th, 2020. The first case in California occurred in January 26, 2020 at Hoag Hospital, Irvine, after a patient traveled from Wuhan, China. It was declared a California state of emergency in March 4th, 2020, and the mandatory stay-at-home orders occurred on March 19th, 2020. So as you can see from the slide, it took a while to have the dramatic acceleration of transmission of the coronavirus, and also a big delay in testing for it. So some of the delay may have been just because there weren't enough tests available initially. But once it got going, it grew at a logarithmic rate at this very sharp curve, and was slowed only by the dramatic quarantine measures that were enacted. Unfortunately, as you can see from this slope, unlike our European friends, the disease has continued to percolate through our community, and actually now it's accelerating at quite a rapid rate, the fastest it has been recently. We know the rate of positive tests is increasing. It's definitely true that more people are being tested. However, concerning is that the rate of hospitalizations in California is spiking at this point, and that's concerning because ICUs can be overrun. We can run out of respirators and facilities very quickly if a significant number of people become critically ill all at the same time. Here are the numbers in California. These are relatively recent numbers. Over 270,000 total cases in California thus far, and over 6,000 fatalities. Of almost 6,000 confirmed cases have been hospitalized, and almost 1,500 suspect cases have been hospitalized. Of those, 1,700 have been admitted to ICUs of the confirmed case, and 231 of the suspected cases. So one question people frequently ask is, how deadly is COVID-19? And some people are frustrated because these numbers have been changing over time, but it takes time to collect the appropriate data to have the best numbers. However, the most latest numbers are much more accurate than some of the earlier numbers. Recent incidence fatality rates have been estimated to be about 1.4% of patients who contract the virus are dying. That's very high when you compare it to other viruses such as the influenza virus. Especially in those 65 years and older, 14% incidence fatality rate, which is very, very high. And this has resulted in about 132,000 deaths in the United States thus far. To further compare this to an influenza outbreak, we believe typically an influenza incidence fatality rate may be on the order of about 2 in 100,000, so much less than 1.4 in 100 or 14 in 100. So this is much more deadly. And also important is the infectivity of this virus. It's transmitted between people much more easily than it is, say, an influenza virus, which is also a very infectious virus. To compare the deaths, in 2018, the influenza deaths were about 80,000 that year, which was a particularly bad influenza year. So we've already passed that, and unfortunately it appears that at least infection rates are accelerating. So now I'm going to turn to more specifically talk about stroke and COVID-19. It is true that very little has been published about stroke and COVID-19, although anecdotal reports are significant and suggesting that there's a significant relationship between stroke and COVID-19. How would this happen? Well, there's a couple potential mechanisms of stroke in COVID-19. One is that recent bacterial or viral infections cause stroke by cardioembolism or arterial embolism. In other words, when somebody's very sick from an infection, they have a higher incidence of clots coming from their heart or from their arteries and causing large vessel strokes. In fact, about 31% of critically ill ICU patients develop thrombotic or clotting complications outside of a COVID infection. However, this is also found to be significant with COVID patients from a couple different sources. In some COVID patients, antiphospholipid antibodies and abnormal von Willebrand factor has been estimated. rather measured. These are clotting factors in the body that make it more likely that someone will have a blood clot. We've known for a while that viruses can stimulate the development of antiphospholipid bodies, and following an infection, someone can have what we call a hypercoagulable syndrome, where someone's more likely to clot or have a stroke. Turning now to the Wuhan experience, which they've collected data on some of the earliest populations, they had estimated a hospital incidence of stroke on the order of about 5%, which is very high for all comers. They also found that it was more common in older patients over 65. More recent studies have estimated a little lower incidence. There's a New York experience that in a retrospective cohort of 2 New York City academic hospitals, approximately 1.6% of adults with COVID-19 who visited the emergency department or were hospitalized experienced ischemic stroke. This may be lower number because a better quality of data, more complete cohort of data. However, it also included patients who went to the hospital but were not hospitalized. So it may be that hospitalized patients actually do have a higher incidence of stroke. On my old hospital, where I came from, Mount Sinai Hospital in New York City, they had a report of a 2-week period between March 23rd and April 7th of 5 large vessel strokes in patients less than 50, which is very unusual. They looked back in their data to every 2 weeks prior to the 12 months prior to when COVID was thought to be an issue, and found only 0.73% of large vessel strokes in patients less than 50. So even though it's more deadly for patients over 65, we're finding that younger patients are having very serious health complications, including large vessel strokes related to COVID. But the data is limited, but that's what we know so far. A great concern that I have is that people are not coming to the hospital appropriately when they're having stroke symptoms. This is an article that was published in the LA Times recently that I was interviewed for, entitled, "Where are the strokes and the heart attacks? Doctors worry as patients avoid ERs." And I was interviewed because of my concern that patients are not coming in immediately when they have their stroke symptoms, and we're seeing patients come in later or not at all. And unfortunately, they do not qualify for treatments that we can give them right away. Here's a graph that shows the effect of COVID on our stroke volumes at Hoag Hospital. And you can see the dramatic decline of about 50% of acute volumes of stroke patients due to the COVID lockdown. People would come in later and say they were just afraid to come to the hospital. But I have to emphasize the importance of coming to the hospital as soon as acute stroke symptoms are detected, because the likelihood of suffering serious morbidity or mortality from the COVID is much less than from an acute stroke. And precautions are taken to protect patients as soon as they enter the emergency department to prevent any possible contamination occurring while they are hospitalized. Few other places are as stringent with their prevention requirements as in the hospital. Turning to how you recognize an acute stroke, we like to teach this mnemonic, ACT FAST, or FAST standing for face, arm, speech, time. Face stands for, ask the person to smile, does one side of the face droop? Arms, ask the person to raise both arms. Does one arm drift downward? Speech, ask the person to repeat a simple sentence. Are the words slurred? Can he or she repeat the sentence correctly? And time, if the person shows any of these symptoms, time is important. Call 911. Here in Orange County, we've helped to develop stroke receiving centers, of which Hoag is a stroke receiving center. When you call EMS, they're trained to recognize stroke symptoms and deliver you to the hospital as fast as possible and call ahead so we're ready to treat an acute stroke. Call 911, brain cells are dying. It's estimated that every minute after an occlusion of a cerebral vessel and patient experiences stroke symptoms, 1 million brain cells can die every minute. So getting to the hospital, getting to treatments as soon as possible is essential. And here's a visual depiction of what occurs. Early on, when somebody has a blockage of a blood vessel by a blood clot, there may be a small area that's permanently damaged because the flow of blood is so low. But there's usually a larger area that we like to refer to as the ischemic penumbra, or the tissue that's at risk but potentially savable. But as time ticks on, the structural lesion enlarges and the penumbra is eliminated until the patient may have a large permanent deficit. On the next slide, we see the typical images that we can obtain very rapidly using CAT scan technology. And you may be able to recognize that on the right side of the screen, that builds cerebral artery. And if it remains there, a very large stroke will occur and the patient will sustain soon after their symptoms develop. For 0 to 4.5 hours, we can give a treatment called intravenous TPA, which stands for tissue plasminogen activator, which is a clot-busting drug normally found in our bloodstreams, but we deliver a concentrated bolus of medication to try to break up the clot, restore blood flow, and save as much brain tissue as possible. We also have other types of therapy called intra-arterial therapy, where they actually guide a small catheter or tube through an incision in a blood vessel in the groin up to the abnormality in the brain and can actually remove the blood clot. We can do this treatment depending on many details up to 24 hours after the patient was last seen normal. We have a device called a penumbra device, which is an aspiration catheter that sucks the clot out. And we also have devices such as a solitaire called a stent retriever, which can actually snare the clot and pull it out. This is a picture of a solitaire device that's pulled a blood clot out of a cerebral blood vessel and is pulling it down outside of the body and away from harm. So I want to just review stroke warning signs in a little more detail. They include sudden change in vision or blurred or loss of vision, sudden confusion or difficulty of speech, such as slurred or sluggish speech, loss of words, difficulty understanding words, sudden weakness or loss of strength in the face, hand, arm, and or leg on one side of the body, sudden loss of balance or dizziness, such as difficulty walking or clumsiness, sudden change in sensation, including heaviness, numbness, or unusual sensations in face, hand, arm, and or leg on one side of the body, and sudden severe headache or the worst headache of my life. If you sustain any of these symptoms, call 911, remember that time is brain, and get to the hospital with EMS as soon as possible. Now just a word on how to protect yourself. The most important thing is to keep your hands clean. This includes washing your hands frequently or sanitizing your hands after you've had contact with other people, packages, or just been out in the environment. When you get home, wash your hands. Wash your hands frequently. Social distancing is the second most important thing. As we said, keep at least 6 feet away, as this usually comes from sneezing, coughing, or just speaking to other people as droplets pass from one person to another. Wearing a mask is important, particularly in close quarters, indoors, or where you're not able to maintain appropriate social distance. That wearing a mask can help keep aerosolized particles from transferring from you to another person. It's important that even when you wear a mask inside, that you still try to maintain appropriate social distance, since that remains the most important thing. However, a mask may help protect people from you from transmitting the virus. Thanks so much for your attention. I'd be happy to answer some questions.
to strokes?
So one question we've had is, are younger people more vulnerable to COVID with strokes? I think that people of any age could be at risk for strokes due to COVID. I discussed we had relatively limited data at this point. However, the fact that even younger people who don't have other risk factors for stroke are having large vessel strokes is very concerning. So I think it's a risk factor for all ages.
Second question, how will my stroke and COVID-19 be treated at the hospital?
So one question we've had is, how will my stroke be, COVID stroke be treated at the hospital? Is it any different? It's no different than any other stroke that comes to the hospital. If somebody's had recent stroke symptoms, it's treated as an emergency, and we treat that as soon as possible. However, when people come to the hospital with acute illnesses, we're being very careful about protecting those patients from any transmission of COVID, and also protecting hospital workers, physicians, nurses, and other patients if you have a COVID virus or suspect or even might have a COVID. So very stringent measures are in place in the hospital to protect everyone. So if you're having stroke symptoms, please don't delay. Get the treatment you need. That's the safest thing.
No more questions.
Okay, thanks for your attention.